Welcome to video 3 in the Safe Recovery Training Program. This video is focusing on risk-taking, not risk factors, to prevent falls in hospitals. I'm Terry Haines. The objectives of this video are to understand the difference between focusing on risk factors as a preventive approach and focusing on risk behaviors as a preventive approach, to understand the limitations of the risk factor approach in the hospital setting, and to understand why older hospital patients take risks that may lead to falls while in hospital. Now, the risk factor approach. Falls in hospitals are different. If we just look at the rates of falls here, we have the rate of falls per 1,000 days from 3 trials conducted in New Zealand by John Campbell and Claire Robertson and their group. And we see that the rates of falls happen to be around 4 per 1,000 days. When we look at some of the recent studies conducted in the hospital setting, we see that the rates of falls are much higher. These older adults are falling over at a much greater rate. When we look at additional nursing home studies conducted in New Zealand, we see that the rates of falls are higher than in the community, but not substantially higher. So these rates of falls in the hospital wards that have been targeted in these studies have been very high. Risk factors can also be different between different settings. We see in the hospital setting from this particular publication, we found that males were at a higher risk of falling over than females when in hospital, and this was significantly so. This contrasts with other studies from the community setting which have either found no gender bias or a female gender bias in terms of being at higher risk. Also in the community, we find that older people are at a higher risk of falling over, but on these rehabilitation wards that were examined in this particular study, there was no age bias identified, that if you're young enough to be admitted to a rehabilitation ward, then you're at just as much risk as older people who are admitted to rehabilitation wards. Now, it's difficult to explain why these risk factors might change, because when I first started learning about falls prevention, my understanding was very much centered on this multifactorial falls risk ideology, that there were factors that just increased the risk of falls regardless of setting. And that was how I conceptualized falls risk to begin with. And one way to balance both the intrinsic and extrinsic factors, so the intrinsic being the ones that a patient brings with them to hospital, and the extrinsic ones are the ones that we have waiting for them when they arrive at hospital. We have a summation of falls risk for the patient based on this overall profile of intrinsic risk factors and extrinsic risk factors. Now, this model I like to refer to as a TIE fighter model because of how it looks. However, in the TIE fighter model, we often focus purely on the intrinsic risk factors of the individual patient rather than the broader extrinsic factors, because these don't necessarily change. The extrinsic factors don't change from patient to patient because it's that same hospital environment that we have for them. Now, this way of thinking is what's dominated our current approaches to falls prevention. If we look at some common falls risk assessment tools that can be used in the hospital setting, we basically see a list of falls risk factors that the individual has and some sort of arbitrary scoring system that they get assessed against and potentially get reassessed against later on in the patient's stay. If we think about falls, though, using the person, task, environment model, we can see that the risk of falls is contributed to by the individual, their environment, but also the task that the person is trying to perform at the time. Having a broader framework that incorporates both the task and the environment means that risk screening tools that focus purely on intrinsic factors will only tell us a part of the problem. This was demonstrated in a study I led back in 2007, where we looked at falls risk screening tools and conducted a systematic review of their predictive accuracy. And I called this paper design-related bias in hospital falls risk screening tool predictive accuracy evaluations, because the way that the research had been conducted was inherently flawed. When you focused on the well-conducted research in this field, the results indicate that the accuracy of the screening approaches that we had been using was quite poor. This index here on the y-axis is called the Uden index. A score of 0 you can get by flipping a coin. That's random chance. A score of 1 is perfect prediction. Now, in most clinical areas, you want accuracy up in this range here. But as you can see, none of the falls risk screening tools that have been evaluated properly got anywhere near that level. So there was a big missing part of the picture. And for me, based on the experiences that I'd had as a clinician, it was very much based on the risk-taking behavior of patients. And this is something that I've conducted a lot more research in since. If you want to get an in-depth understanding of this area, have a look at this publication, Why Do Hospitalized Older Adults Take Risks That May Lead to Falls? And that's published in the journal Health Expectations. The aim of this study was to explore the differences between situations that promote risk-taking in most people and situations that promote risk aversion. We conducted interviews with hospital patients from inpatient medical and rehabilitation units, both 2 weeks and 3 months post-discharge, so that they wouldn't feel pressured into giving hospital-friendly answers, so they'd really give us their honest opinions. We also interviewed their informal caregivers, usually their spouses or children, and also health professionals who work in these settings. We identified from the study that there were different types of risk-taking. There was what we called enforced risk-taking. These were instances where an older adult felt they had no alternative but to attempt to perform the task in question. And one of the quotes that we had from the study was, "When you've got to go to the toilet, you've got to go." We also classified some risk-taking as voluntary, where an individual felt they had a choice as to whether they performed the activity or not. So in the following quote, there's an element of recognition of choice by the patient. They said, "When I go to the toilet, I was usually in a hurry and that thing, the over-toilet seat, was out of position. I used my crutches to drag it over the toilet. I could have easily fallen. I could have asked for help, asked somebody to put back the toilet seat. But I thought, no, I won't bother, and I did it myself quickly. I did. Lucky I didn't fall, but I could have." Now, this voluntary risk-taking, we subclassified into 2 types. We had informed voluntary risk-taking, instances where the individual decided to take a risk when he or she was aware of the risks involved. Also, malinformed voluntary risk-taking, instances where the individual decided to take a risk when not fully aware of the risks involved. Now, to try and conceptualize how we classified risk-taking, we have the enforced risk-taking over here, we have the voluntary risk-taking here, and the 2 types. Informed voluntary risk-taking, so this is someone like an athlete who decides to undertake an athletic endeavor knowing full well that there's a risk that they might fall over. Compared to malinformed risk-taking. Here, this unfortunate lady at a wedding dance might have been malinformed of the dancing capability here of her dancing partner in the pink shirt. Might have been telling her that he was a wonderful dancer, and we've got some evidence to the contrary. Now, this risk-taking was contributed to by 5 key areas. We've plotted these areas out in these little circles here and put them on the background of the person, environment, task framework. Again, these overlapping circles to try and indicate where there's factors very much related to the older adult, to both the environment and the older adult, and also the task involved. Let's go through these one at a time, starting with risk compensation. Here's a couple of quotes. This one is from a staff member. Patients have cognitive issues and do not realize that they need assistance, or are therefore getting up and without the assistance or walking aid they need when they're walking. Another quote, this time from a patient. And the ward where I was did have a lot of stuff in the corridor. The blood pressure monitor, machines and trolleys, all sorts of things. It was horrible. If I wasn't paying attention, I could have tripped over. In both situations, we're talking about risky behaviors or difficult tasks that the patient is trying to perform, where they can choose to try and avoid the activity or to pursue the activity. Being aware of the self, being aware of what someone is able to do for themselves is critical. Being aware of the demands of the task is what they need to weigh this up against. And there needs to be this active consideration of these two key elements. Awareness of the self and what a person can do, and awareness of the task. Now, in hospital, the awareness of the self may be very much distorted because of the person's health. They may have had an illness or a surgery which has dramatically reduced a person's ability to perform mobility tasks or to functional self-care tasks around the bedside. Their ability to perform those tasks having been reduced may mean that they have to change the tasks that they try to undertake. The tasks themselves may be more difficult in the hospital environment because it's a different environment to what the older adult is used to at home. Having some cognitive decline may impair the ability of the individual to be aware of themselves or be aware of the difficulty of the tasks they're trying to perform. There are also some people who are in denial about their loss of ability, or some others who are just very resistant to change. All of these things can affect whether an individual undertakes risk compensation, whether they change the types of activities they try to perform in light of the difficulty of that particular task. The next area that we want to focus on is not asking for help. Here is a couple of quotes from patients. The first, I'd been to the toilet 3 times and I wanted to go again. And when she came, she went, profanity, and put her hand up and flopped it down to show, not you again. Another patient said, he, another patient, was ringing his bell a lot, but that was just because he needed a lot of help. He couldn't see where things were, whereas I didn't ring my bell. Not because I didn't need help, but because I knew if you ring too much, they get cross with you. They came and they would lean against the wall. Staff would say, what is it now? With a bad-tempered attitude, like you are a nuisance. These are pretty confronting statements from patients about the care that they've received. And there were many more like them, unfortunately. Many more things that impact upon whether a person is going to ask for help. Now, these particular experiences could be classified as negative past experiences that may prevent a patient from asking for help again in the future. They may also impact upon the trust they have in the health professionals caring for them, that they're either willing to help them or that they're going to be able to effectively help them and prevent falls, even if help is provided. Some other reasons were quite surprising. One reason offered was that the patients think that the staff looked unfriendly, which I had difficulty reconciling when I first heard that statement. But when you think about breaking down by the side of the road and having to go to ask someone for help, and if there's people who look friendly versus people who don't look friendly, I guess I'd go to the people who look friendly before asking for help first. There was a perception that staff were not allowed to help. In a rehabilitation ward, staff are often telling patients that you have to do things for yourself. But if a patient overhears this from another bed, they may mistakenly think that it applies to them at their particular time and their particular circumstance. So that's a potential, I guess, eavesdropping problem that you can have, particularly in multi-bed rooms. There is also the perception expressed that staff are too busy to help. I can very much understand why patients might have this perception, because staff are often very busy with the number of tasks they have to perform to be able to get through a shift and complete all the work that they need to get done. So if a staff member walks into a room looking busy, I need to do this, I need to do this, and I need to do this, and they appear to be very task oriented, then many patients won't want to add to that perception of busyness, which leads to this side not wanting to be a burden, which is a very common perception held by patients, not wanting to make the job of the staff caring for them any harder. There is a perception, again as expressed by some of those quotes, that the staff will not like the patient if they do ask for help. Also, the act of receiving help can cause embarrassment. This is something that came up particularly for older men with receiving help to go to the toilet. It's not so much that they are embarrassed to ask for help, but the fact that if help was actually provided while they tried to use a urinal or go to the toilet, they would be embarrassed by that, and that dissuades them from trying to ask for help. For other patients, they have a strong belief that they can perform the task without help, and that relates back to that risk compensation and weighing up of their assessment of their own ability versus the difficulty of the task. Some groups have cultural beliefs relating to whether they should be asking for help or not, or who they should be asking for that help from. Some patients do express embarrassment that they need help at all. Some have a very strong desire to be independent, that they don't want help, that they can care for themselves. Other people have an impaired capacity to ask for help, whether that be the cognitive faculties to be able to know when they need help and to use the nurse call buzzer system, or others there might be communication impairments such as an aphasia. The next area that I want to focus on is decreased or delayed provision of assistance once it has been asked for. Here's a quote from one of the staff members. "Today we're understaffed. You're running to try and give them their meds, let alone to try and toilet them. You just don't have the time in the day. We're being pushed to our extreme that the nurses can't keep up anymore." Really expressing the busyness there that the staff members on the wards operate under. And there's a range of factors, many related to the health service systems and staffing that contribute to that, but other factors such as the physical structure of the ward environment, competing tasks amongst health professionals, having to focus on a range of different tasks that all lead to decreased or delayed provision of assistance. If I asked any staff member the one thing that they would need to help prevent falls in their patients more, I'm very confident that I'll get the response time. If only I had more time, I'd be able to do it better. However, we did collect some evidence saying that interaction with family members and patients with the health professionals and the hospital staff members can promote better provision of assistance. If there is negotiation, discussion between staff members and patients, staff members may be able to better understand the individual needs of the patient. The next area that I want to focus on is communication failure. Here's an example using a couple of quotes to try and highlight the difficult situation that some of the patients are in. So the first quote is from a nurse. "We've just got to keep on reiterating," in reference to what the mobility prescription is. So if the patient's been told that they can't walk around their bedside unless they've got their walking frame and a nursing staff member there to help them, then they have to keep telling the patient this. That's all they're allowed to do. However, the physiotherapists when discussing the mobility prescriptions that they've provided and whether patients adhered to them. Said, I think you know when patients aren't doing exactly what you want them to, but it's letting them and another physio in this group discussion chimed in, an acceptable risk. The first physio responded, yes, an acceptable risk, and letting them get away with what you actually want them to get away with. The second physio then chimed in again. I mean, no one likes to be treated like a child, and that's virtually what you're doing when you're bossing someone around. So, can you understand from the patient's perspective why it's very difficult for them to be in this position? They want to try and be compliant. They have a reasonably restrictive mobility prescription put on them by the staff, and my concern is that the staff are being overly cautious in their mobility prescriptions, which is literally forcing patients to be non-compliant with those prescriptions. On one hand, the physios are telling them, oh, don't walk around unless you've got the nursing staff member with you and the gait aid. The nursing staff are reiterating this to the patient, but the physio then is quite thinking that it's okay if you don't do it. It's an acceptable risk. Again, this is a difficult situation, and this may not be consistent across all the different hospitals that you may work at, but it's a difficult situation for patients to be in when they're getting conflicting messages from the different staff members. Now, there are many reasons why you might get a communication failure with the patient, and this can very much lead to risk-taking that is malinformed. If they're getting the wrong message or hearing the wrong message, they might take risks they didn't need to or want to take. If patients get mixed or incorrect information, then that can lead to problems, certainly. But then there are other factors that might be related to the communication approach used by health professionals. The amount of information provision. Often I see a ward round where a patient is provided with 15 different pieces of information by the team treating them, and they've got no chance of being able to absorb all that information all at the same time using a simple verbal framework. The timing of communication is important. If a patient is drowsy, if a patient is feeling particularly unwell, they're in pain, they're all factors that might make it a poor time for them to receive that information. The language used, and particularly the availability of interpreters, can impact upon whether older adults are able to comprehend the information they've been provided with. Also, again, whether a patient has a cognitive impairment can further complicate this picture. The final area that I want to just touch on is the testing of physical boundaries, which again is a very interesting issue in the hospital environment. Here's a couple of quotes. First from a patient. The minute you become confident, you start to do things that you shouldn't be doing, and that's how falls occur. As if the patient is describing an iterative process of testing their boundaries a little bit further, and every time there's a success they can test the boundaries a bit further up until the point that they fall, and they've tested them too far. Next quote from a staff member. The family members, they say, Mum is okay, Dad is okay, they don't need the shower chair, they don't need the rail, whereas in actual fact they do. The patient says, I don't normally use a frame, I can walk with nothing. Patients have a picture in their mind of what they used to do, of what they used to be able to do prior to the illness or surgery that brought them into hospital. And if they have that perception as their sense of what they can do, then they may be able to, they may be pushing the boundaries a bit too hard. With the boundaries, there is a strong desire to test these physical boundaries that might be motivated by a range of areas. Commonly we found it's a desire to go home, a desire to be independent, and a desire to return to their previous lifestyle. However, we found that whether people test their boundaries or not can be influenced by encouragement or discouragement by staff members to test these boundaries. As a physiotherapist, one of the things that I used to do was provide therapy and exercise to patients so that they would test their boundaries in order to rehabilitate them. I wanted patients to be rehabilitated. However, by doing that, when I was standing with the patient, led to what I refer to as supported testing of physical boundaries. What is more dangerous, in my opinion, is unsupported testing of physical boundaries. Walking around the bedside unassisted for the first time when perhaps the patient isn't quite ready for it. The confidence to test physical boundaries I've here represented with a couple of arrows indicating that there's that cycle. That patients will continually try to test their boundaries until they get back to their previous level, possibly in an unsupported manner. So all of these factors are things that we've found that have led to risk-taking behaviours on the hospital wards. And in the research that we've discussed in the previous video, we've found that trying to modify these risk-taking behaviours and trying to enhance the ability of the older adult to ask for help and to wait for help to arrive, we can reduce falls dramatically by focusing again on risk-taking behaviours, which may be present in the absence or presence of risk factors. It's not so much which risk factors you have that's important, in my opinion. It's what you choose to do in light of those risk factors, the presence of those risk factors, that is important. And that's something that is very much the central heart of the Safe Recovery Program, helping people to become rehabilitated, helping people to recover, but to do so in a safe way by focusing on the behaviours that might be excessive risks for them to be taking at that particular point in time in their recovery.